I have nothing to declare for this presentation. So when you assess a patient with critical limb ischemia and infection, you have to understand that revascularization is not enough, is not sufficient to treat infection, as antibiotic therapy is not sufficient to treat the in a comprehensive condition these patients. Um, Diabetic foot infection treatment accounts for more than one quarter of all diabetic admission in both Europe and the United States. So it's probably the most common reason for diabetes related admission in the hospital. More than 50% of individuals with foot ulcer have sign of infection at the first presentation, and one third have a sign of both peripheral artery disease and infection. If you take in consideration the Aerodile, a study, multi-center study that was published in 2008 from with data from 14 centers in Europe. You can see that 50% of the patient presented some degree of critical limb ischemia, and 60% of the patient, the same patient, has some kind some sign of infection. So you know that approximately two-thirds of lower extremity amputation are the result of an infected ulcer. So surgery should be considered an essential part of the multidisciplinary approach when you have an infection in the diabetic foot. This is the classification of an infection disease society of America about the foot infection. We have four classes from uninfected, mild, moderate, severe. And when you have a moderate infection with arthritis, with osteomyelitis, deep infection, you have a limb threatening infection. And if you have a systemic inflammatory response sign, like in the severe, you have severe stage, you have a life-threatening infection. There is in the international working group guidelines, there is an agreement that for moderate and severe grade of infection, immediate surgery should be indicated. So emergent procedures are performed predominantly to limit the progression of infection through the compartment of the midfoot and the hindfoot. And this class of surgery should be performed before the revascularization. You don't have to take in consideration peripheral vascular disease when you have an acute infection, and the patient should be immediately brought to the OR for the surgical drainage. There are some statements that support this idea. There are many papers that demonstrate that you need to perform an immediate surgical procedure because prompt surgical treatment may reduce the need of above ankle amputation. Some authors state that when an infection is potentially life-threatening, you have to put the patient immediately in the OR for a surgical debridement. Any delay, time is tissue, any delay in surgical debridement allows the infection to spread and is associated with a higher level of amputation. The Diabetic foot infection produces destruction of local microcirculation, and antibiotic cannot penetrate in the site of the infection. And surgery reduces pressure in the affected compartment of the foot, and aggressive debridement allows the surgeon to establish which layer are affected by necrotizing process and the extent of the infection. This is very important statement. Remember that the surgical debridement is a surgical procedure, so pay attention. Don't uh, use the surgical debridement in the outpatient clinic or at bedside. You need the anesthesiologist, you need that you are to control bleeding, to control pain. Remember that the infection coming from the forefoot start to invade the medial column or lateral column in the midfoot and in the deep compartment. So it is necessary to follow the fascial planes to control the risk of spreading of the infection. Another important point is that when you have an acute infection, it is necessary to prepare the patient to a multi-stage approach. So it is not possible to create the surgical debridement and to have the primary intention closure. Many times you need to debulk the soft tissues and bone infection. You have to leave open the surgical site. You have to use negative pressure wound therapy plus instillation of antiseptic agents. As only when you are sure that there is no uh, you have to control the infection, you can close by by delayed primary intention, or you can use other orthoplastic technique like flaps or graft for close the surgical site. On the other side, you have to control deformity because when you have to remove osteomyelitis and some bone structure or osteoarticular structure, you have to fix and to stabilize the foot and the ankle. And this in this case, it is very important to use external fixation for this purpose. This is a patient that has a very large abscess in the ankle. This is a Charcot foot with a complete destruction of the talus. The first, you can see that MRI is very important to detect, to evaluate the amount of infection and osteomyelitis. The first step in this case was the drainage of the abscess. We left open. We removed all the talus, leaving the ankle completely open. We used negative pressure wound therapy with the installation of with polyhexanide, and after 10 days, we put the patient in the OR to stabilize the ankle, use a fusion of with tibia and calcaneal bone, and we stabilize with external fixation. And this is the result after several months. So, in conclusion, conservative treatment is an achievable goal in more than 70% of cases of infection and osteomyelitis. Diabetic foot infection required the rapid and multidisciplinary team assessment. Use of bone culture, histology, MRI is recommended, but osteomyelitis sometimes is difficult to objectively diagnose. Osteomyelitis is not an indication for primary amputation. Spreading of deep infection likely requires surgical inpatient management. The goal of therapy is to prevent amputation and to preserve as much of the weight-bearing surface as possible. Vascular assessment and liberal revascularization are imperative to a successful outcome, but should be postponed after the control of the infection. Thank you very much for your attention.
Thank you very much, Professor. So I think we're going to finish this amazing session about technology and techniques, talking about the very last one, the IVL. So managing BTK heavily calcified vessels with IVL. Do we have the final solution? It's Dr. Shafei.
Thank you, Mr. Chairman. Dear colleagues, good afternoon. I think this answer for this question is maybe it will be diplomatic because no one know the answer. So according to our presentation today, that we'll see if the intravascular lithotripsy